title of my today's talk is Acute Kidney Injury, Developing the Electronic Patient Record in India. Is it possible? Let's hear from patient daughter, patient testimonial.
So what is it? Good afternoon. My name is Deepika. I'm daughter of Mr. Ramesh Khanna, age 79. And we came here almost 25 days back. And 26th day before, I stay in Dalhousie in Himachal Pradesh. So 26th day before, I was having a conversation with my pop, and he said that you walk very less, and I walk almost 7 kilometers a day. And on the 25th day, I got a call from my caretaker that something is wrong and he's not well. There's a lot of fever. I rushed down from Dalhousie to Mumbai, and we brought him to Kokila Bay. And here he was diagnosed of acute kidney injury because of an abscess in the liver. Now, he has always been a very, very fit person, and he's been really taking good care of his health, drinking a lot of water, hydrating himself. So I never thought that this can ever happen to him. Now, what I was told was that, since there's an e-alert system and they kept on monitoring his keratin, as a result of this, they controlled it in time and they did not let this acute injury turn out to be a chronic one. Had it been a chronic one, then recovery would have been very, very difficult, very painful and time consuming. So I'm really thankful to the team of Kokila Bay for diagnosing it with their e-alert system.
So as we all know, the public health perspective of acute kidney injury, it is defined as abrupt decrease or sudden deterioration in kidney function, which results in the accumulation of metabolic waste products as well as dysregulation of volume status, electrolyte and acid-base balance. This condition is very common, estimated to occur 5% to 20% of all hospitalized patients, and it carries significant risk of mortality, around 20% in some studies. But the scenario in India and in developing world is quite different. And if you see around 13.3 million cases every year globally and 1.7 million deaths per year. Amongst them, estimated 11.3 million cases per year in developing countries and 1.4 million deaths per year in low or middle income countries. Because of this situation, electronic health record or electronic patient record or e-alerts can modify patient outcomes, contribute to greater resource utilization, and decrease healthcare cost and financial burden. Let's see how. Coming to lab perspective, the ability to implement real-time AKI interventions such as alerts and best practice advisories has emerged as a promising tool to fight against the harmful sequelae of AKI, which include short-term adverse outcomes as well as progression to chronic kidney disease, dialysis, and death. So we all know about different consensus, rifle, AKI, and AKIN and KDIGO, kidney disease improving global outcomes. Guidelines advise identification of AKI based on increase in creatinine. But the small changes of serum level of creatinine are not detected by clinicians sometimes, so early intervention unlikely, or also urine output monitoring. Sometimes these are not done in all setups, so therefore the detection sometimes missed. This further increases the burden of disease. There are consensus statements by experts who recommend that early personalized investigations and monitoring and management of AKI. The impact of AKI alert, like in this study, they said 0.8% reduction of mortality, length of stay decrease 0.3 days reduction, and dialysis use 2.7% reduction. So these are different causes of acute kidney injury. All of us know pre-renal causes, sepsis, then hypovolemia, diarrhea, vomiting, hemorrhages, and renal syndrome, cardiac failure, hypertension, intrinsic AKI, acute tubular injury due to crush injury, rhabdomyolysis, NSAID usage, gentamicin, and different other nephrotoxin usage, tubular interstitial injury, glomerulonephritis, then myeloma, vasculitis, lupus nephritis, ANCA-associated vasculitis. Coming to the picture in India, sepsis causes around 56% of AKI. Then snake bite, diarrhea, acute gastroenteritis, cirrhosis, congestive heart failure, malaria, dengue, and then ARDS and COVID-19. We know this is one of the major causes nowadays. Then sickle cell disease, obstructive uropathy, dengue, acute pancreatitis, scrub typhus, hemolytic uremic syndrome, HELP, bee sting, eclampsia. So the scenario or causes of AKI in India is different. So some examples of AKI warning system, like NHS England implemented that in March 2015, that all the lab system, biochemistry department lab system or LIS issue AKI warning based on raise in serum creatinine level, and they have say different type of e-alerts, AKI care bundle or AKI outreach teams help the clinicians to identify the patients with AKI. So e-alert system or electronic alerts are key interventions in patients with AKI to improve management of patients. It's important for early diagnosis of AKI via e-alerts to improve the diagnosis of AKI. Studies shows that e-alerts can affect the behavior of the clinicians, reduce the use of nephrotoxic drug, and improve the prognosis of AKI. An automated screening process that reports AKI has been implemented throughout the NHS in England. It's driven an algorithm-based AKI e-alerts like depicted in NG148 or CG169 guidelines developed by NICE. So e-alert, the efficacy is dependent on multiple interrelated factors as schematized in the conceptual model I'll describe later. The alerts are least effective when provider is already aware about the clinical situation. This is called endogenous recognitions, or when the alert is not actionable, they can't stop the nephrotoxic drug, or there are no therapies, alternative therapies available. The conversely, alert may be most effective when providers are unaware of AKI in situations where creatinine is rising slowly or when actionable steps are immediately available. So several studies shown the potential efficacy of the alert system in the hospital setting. The factors for e-alert success include speed of information system, timing of the alert, real time and stat timing, minimal disruption of and integration into the provider workflow, the simplicity and clarity of the message, and provision of references and sufficient information within the alert. So if we see this is a conceptual model, AKI e-alert, the favoring factors are lack of recognitions of AKI, because this is heterogeneous causes and heterogeneous settings where it is detected, and limited experience with drug dosing of nephrotoxins and likelihood of progressions, and the discouraging factors like endogenous recognitions, which may lead to alert fatigue and lack of alternative therapies. So if we see the effectiveness versus intrusiveness of e-alert, alert effectiveness strongly related to the degree with which it intrudes on the usual process of care and creating a conflict in terms of clinical outcomes. So there are different types of alerts: passive alerts, then electronic health alerts, no acknowledgement required, or e-alert where mandatory acknowledgement required. These are kind of soft stop alert, and the hard stop alert where clinician has to take action based on e-alerts. So the potential benefits are reduction of medication errors, early identifications, and appropriate treatment of under-recognized conditions, enhanced quality of care, then improved patient safety and outcomes, and the potential harms of electronic medical record alert system, risk of development of alert fatigue amongst the clinicians due to poor clarity, low specificity, low sensitivity, high frequency, disruption of the workflow leading to decreased attention to the clinically important alerts, increase in attention to non-alerted patients due to increased reliance on the alert system, or unintended adverse consequences when alerting overrides the physician's judgment. Therefore, limitations are potential for false positive alerts, which may undermine alerting and reduce provider adherence. And alert criteria may serve as poor proxies for true disease progressions like EGFR in kidney disease. Difficulty of direct integration of alerts into the electronic health record system, and possible lack of generalizations of alerts to different care settings with varied practices and patients populations. So we all know the KDI geo guidelines and AKI definitions increase in serum creatinine by more than equal to 0.3 milligram per deciliter within 24 hours, or increase in serum creatinine more than equal to 1.5 times from the previous measurements, which is known or presumed to have occurred within the prior 7 days, or urine volume less than 0.5 ml per kg per hour for 6 hours. And these are different stages like stage 1, 2, 3 based on serum creatinine value and based on urine output. So for us diagnosticians, every blood sample tells us a story. Let's see how. So when we plan to implement AKI alert, so this is the business model canvas. I was doing the transformational leadership program under IIM Indore. So this business model developed by me and our research intern Ujja Parekh. So this is like we define the key partners who are the key stakeholders, physicians, nephrologists, intensivists, emergency room physician, nurses, then IT team, the key stakeholders, key activities, then motivation for the partnership, value proposition, how we are going to implement that, then customer relationship, what will be the patient outcomes, then customer segments, we have chosen the adult population for pre-implementation stage, then key resources, then channels, then cost structures, how it will affect the financial burden of the patient, and revenue streams, how it will impact on the hospital revenue. So then we have taken the period of 20 days and inclusion all patients more than equal to 18 years. Then exclusion criteria are like initiation of dialysis, patient on dialysis, and end-stage renal disease diagnosis code, or on admission value more than equal to 4 milligram per deciliter, or patients within 6 months of kidney transplant. So we have excluded with the previous history of this. And criteria for triggering alert for our case was 1.5 time rise in serum creatinine from the lowest creatinine value within the 7 days period, and more than equal to 0.3 milligram per deciliter in serum creatinine rise from the most recent creatinine value in the last 48 hours. So this is like a display in the clinician's screen. Patient safety advisory AKI alert. Please rule out the possibility of acute kidney injury. So relevant creatinine values over the last 7 days, most recent, lowest in 7 days, and highest. And the second criteria, relevant creatinine values over the last 48 hours are listed below, most recent, lowest, and highest. So exclusion criteria also we mentioned, and also there are option for agreement and disagreement, and clinician can write and explain the reason for disagreement, if any. So this is our critical call log, where we telephonically inform the clinicians about AKI alerts. So this is due to difference in 1.24 milligram per deciliter in 48 hours. We write the reason, and this is AKI alert due to 1.5 time rise in creatinine value in 7 days. So this is telephonic alert informed to the nurses and clinicians. Then alert firing protocol algorithm will be integrated with the formula described in the previous slide in patient database software. An alert will be triggered when serum creatinine level rise as per the criteria described previously within an hour of detection. So it will be informed to the physician, nurses, and lab professional. And there can be telephonic informations or communications, email or text-based alert. And This study outcome variables, age, gender, total number of patients evaluated, patient diagnosed with AKI with AE alert system, total number of AKI documented, then stage and progression of AKI, length of patient stay, mortality in hospital. So this is our flow chart where this is serum creatinine value, and if it is more than equal to 3 milligram per deciliter in 48 hours, then AE alert raised. And also we monitor it in 7 days. If we find the most recent creatinine value, that is C1, and establish the baseline value of lowest serum creatinine in last 7 days, that is RV. So this C1 RV divided by RV, if the ratio is more than equal to 1.5, then the alert is raised, and we define the stage. Stage 1 is if the ratio is more than equal to 1.5 to 2. Stage 2 is more than equal to 2 to 3. And stage 3 is when the ratio is more than equal to 3. So this is our study, around total patients of 4,708. And we excluded the pediatric patients. The inclusion is around 4,439. And E alert was raised in 273 patients, and true AKI E alerts was 239, and this was around 5.38% in the hospital setting, ward, ICU, and OPD. And false AKI E alert was 34, and non-AKI was 4200. So this is the included patients, and this is graphical representation. This is true AKI E alert. And this is the box plot where we can see the range. Range is starting from 1.3 to 2.4 for AKI, and these are non-AKI range, and these are outliers deleted based on the exclusion criteria. So this is stage-wise, around 202 patients in stage 1, around 18 patients in stage 2, and 19 patients in stage 3. And this is the median value and range of AKI stage 1 and stage 2 and stage 3. So this is the box plot for that. And we have done the clinical validation of our data. For that, we have taken 2,000 subjects. So included patients was 1799, and we have seen number of AKI E alert is raised in 2,000 patient was 143. That was 7.9% in the hospital setting. And number of patients with documented AKI diagnosis by clinicians in the report or the clinical system, so that was around 46. So this is the graphical representation of that. So coming to, we are in search of troponin for AKI or earliest biomarkers. So there are novel biomarkers, including neutrophil gelatinase associated lipocalin, NGAL, kidney injury molecule, KIM1, interleukin 8, liver tie, fatty acid binding protein, insulin-like growth factor binding protein 7, and tissue inhibitor of metalloproteinase TIMP2. So we all know that decreased glomerular filtration we see by serum creatinine and serum cystatin, and urinary markers of AKI for predicting tubular stress or injury like KIM and interleukin 18 and NGAL, LFA-BP, and IGF-BP7 and TIMP2. So few studies indicated that these urinary markers of AKI are earlier reflections of renal damage than the conventional serum markers. Why? Why we need that? Because typically serum creatinine will take 24 to 36 hours to rise after a renal onslaught, so delayed marker. Because more than 50% of renal function loss for increase in creatinine. Therefore, these markers like KIM1 or IL-18, this they detected early, like KIM1 detected earlier in 12 to 24 hours, and IL-18 as early as 6 hours, and NGAL and FABP peak at 6 hours. So despite that earlier detectable presence of this marker in urine, but it's remain unclear if the serial sampling is necessary, like troponin in acute myocardial infarction. So the standardization of these biomarkers require. And also, like, this is unclear how to implement that and how to use those earlier biomarkers. So now coming to electronic health record, we get the data and then it combines text and numeric data from average data sources. We apply the rules based on subject matter exposed different algorithm shown, and it delivers high quality care with patient-centric insights, reduce variability through consistent guideline-driven recommendation, improve workflow and efficiency, it improve revenue, suggest patient-specific next step, test and discharge advice, improve quality, standardized treatment protocol as per local and international guidelines, repository of guideline-based recommendations available across multiple key stakeholders, and it improves patient satisfaction, provide patient-specific interpretation and next steps, improve standardized care by flagging patients, apply risk algorithms, and provide better interpretation and decrease length of stay and economic burden. So this electronic health record by creatinine-based model, this has multiple implications, and it can be used in a bigger setup like national level setup. So we identify the management and then expand and transform at national level. So this is our future plan. We have taken the baby steps, and but there are miles to go, like Robert Frost said. So machine learning based model or deep embedding model for diagnosis, prognosis, and therapeutic interventions of acute kidney injury. And we can use LIS and HIS tracking of serum creatinine in real time based, and identify features associated with AKI using the machine learning or deep embedding or deep model. So the features may be demographic data, clinical findings, cytology, ICU status, clinical biomarkers, and functional status score, and previous uses of nephrotoxic drug or nephrotoxic drug if it is used. And we can compare that with the different earlier biomarkers like TIMP2, IGF-BP7, and NGAL, FABP, or IL-18. And there we split the data. One is the train set and one is the control set or test sets. And we see the conceptual model with the implementation and the outcomes of mortality, complications, patient readmission rate, nephrotoxic dose reduction, and prediction for need of dialysis or renal replacement therapy. And ultimately, based on these two models, train set and test set, we calculate area under the curve and sensitivity and specificity of e-alert system. So we have taken the baby steps. We begin our journey to transform healthcare. Future is implement that at the national level, and based on AI or artificial intelligence, machine learning, deep embedding based real-time prediction of acute kidney injury. It will improve healthcare outcomes, standardize interpretations and next steps, and improve quality and training and save clinicians' time to refocus on better outcomes. So this is my painting. Clinicians, nephrologists, physicians, you are healing, you are the healer. But if you see this extended hand, that is ours. We diagnose patients through this electronic health record or ELR based on creatinine. We are helping you to heal